All right. Thanks everybody for joining. It's great to see everyone. I'm glad weren't too many hiccups with the links. I know we're still working out some kinks in the new system. So thank you for everybody being patient and willing to join and participate in the project. We're really excited about this. Today is going to be, we have a jam-packed session, so we'll get through as much as we can. But we're going to do introductions. We're going to go around the Hollywood squares. And we're going to have everybody introduce themselves. After that, then we're going to do a brief overview of kind of what to expect with Echo, what Echo is. And then Dr. Mintz is going to do the overview of more of the content of the project itself, what covers, what things are going to be covered, who's on the hub team, those kinds of things. And then we do have a case. If we have time, we'll walk through that case as an example case. If not, we'll save it for the next time, but hopefully we'll be able to get through everything, but we want to be also mindful of your time and get you out of here at 1 o'clock. All right, I'm going to start with introductions. My name is Jay Mason. I'm the director of the Project Echo program through the West Virginia Clinical and Translational Science Institute. So I will be your MC for the sessions. You will get emails from me. You will be annoyed at times with me when I send you so many emails, but I apologize. Also, I'm the one you want to contact if you have any issues or if you want to submit a case or anything like that, have a topic idea, please let me know. Don't be shy. Put it in the chat, send me an email afterwards, raise your hand. Any way is fine. I'll just go ahead and go around the Hollywood squares and call people out. Please let us know who you are and where you're from. So Mitra, why don't you go ahead and go next?
Thank you, Jay. Hey, everyone. My name is Mitra Salmasi. I'm the Project Echo Manager at the West Virginia CTSI, and I work very closely with Jay. So if you have any questions, tech issues, you're more than welcome to reach out to me as well. But we're really excited for this launch and for this first session. So we thank you all for being here.
Thanks, Mitra. Samantha.
Hello. So my name is Samantha Mintz. I'm a vascular surgeon at WVU, and I'm the PI of the overall amputation prevention project that's focused in Pocahontas County. And we're very excited, very, very excited to be launching the second phase of our project. And we will talk about that a little bit as we go on. But otherwise, you all know me, so happy to see everyone here.
Thanks, Samantha. Lauren.
Hi, everyone. My name is Lauren Wright. I'm the Research Project Coordinator for the Amputation Prevention Project, which I'm sure you all already know, because other than Jay, I'm the one that emails you the most.
Thanks, Lauren. Kayla.
I'm Kayla Lester. I'm a PA at CCWV in Marlinton. So
Thanks, Kayla. Thanks for joining. Rhonda.
I am Rhonda. I'm Kristen Withers, the patient navigator here at Community Care in Marlinton.
Thanks, Rhonda. Kaylee.
My name's Kaylee, and I'm a medical assistant at Community Care Marlinton.
Thanks, Kaylee. Amy. Oh, you're on mute, Amy, if you're talking to us.
I am Amy Diamond. I'm the Medical Director of Advanced Wound Care here at WVU Medicine.
Thanks, Amy. Tina?
Hi, I'm Tina Walther. I am the Office Manager for Community Care of Green Bank.
Tina. Kristen?
Hi, I'm Kristen Withers. I'm a nurse practitioner at Community Care in Marlinton.
Thanks, Kristen. Quentin, good to see you again.
Yeah, I'm Quentin Brubaker. I'm one of the family practice at Green Bank Community Cares.
Thanks, Quentin. Pamela? There you go.
Hi, I'm Pamela Zimmerman. I'm a vascular surgeon here in Morgantown, and I'm the chief of vascular surgery here.
Thank you. Rusty?
All right, sorry, I had to unmute there. Hey,
That's
I'm
all right.
Rusty King. I'm a podiatrist. My clinic is in Fairmont at the Gateway Clinic, and then I practice out of up at Ruby and UHC.
Thanks, Rusty. Okay, I hope I don't butcher your name. Verity. Right or wrong? Be honest.
Close enough.
Okay.
Sam will tell you that my name has had many pronunciations. I'm Bharati. I'm one of the infectious disease critical care physician up at University of Pittsburgh. And I know Samantha through our residency together.
Oh, thank you for joining. That's my hometown, Pittsburgh. So welcome.
Thank you.
Brittany.
She actually had to step out.
Okay. Well, Mary, why don't you go ahead then?
My name's Mary. I'm Jennifer Lambert's medical assistant here at Green Bank.
Thanks, Mary. Michael.
Hey there, I'm Michael Hurst. I'm one of the podiatrists here at Davis Medical Center in Elkins.
Thanks, Michael. Andrew.
Hi, I'm Andrew. I'm just a med student working with Dr. Mintz here in Morgantown.
Oh, thanks for joining. Appreciate it. Deborah.
Hi, I'm Deb Loy. I'm a specialty care nurse here for vascular surgery at WVU in Morgantown.
Thanks, Deborah. Christiana. Oh, having some technical difficulties. Okay. Thank you very much for putting your information in the chat. Welcome. Jeffrey.
Hi, I'm Jeffrey Michael. I'm a podiatrist down at St. Joseph's Hospital in Buchanan.
Thanks for joining. And Jake. Jake, you're still on mute if you're trying to introduce yourself. Or is this patient?
Yeah. Oh wait,
Okay.
nope. He wrote having some trouble. He
Okay.
wrote in the chat.
Thanks, Jake. Thanks for joining. Yes, please put, if you're having any technical difficulties or you can't unmute for whatever reason, please use the chat. We'll be checking that. And then Melissa, if you wanted to go ahead and introduce yourself.
Sure. Thanks, Jay. My name is Melissa Lobato. I'm with Project Echo, and I'm here to observe this first session in the new platform. Thank you all for joining and for working through the kinks on this.
Thanks, Melissa. Okay. I think that was everybody. Oh, wait, I see Brittany, you're back. Brittany, did you want to go ahead and introduce yourself if you can? If that is Brittany, I'm assuming that is the camera there.
Hold on. I'm Brittany. I'm a nurse
Okay.
at the Community Care of Green Bank.
Awesome. Thanks, Brittany. Okay. So the first thing we're going to go through is I have just a couple of slides real brief about the Project Echo, what to expect in these sessions, and kind of how things will run moving forward. So let me go and share my screen real quick, and we'll go through these slides. Maybe. There you go. All right. So this is going to be real high overview of Echo. If you guys have any questions at any time, please raise your hand, unmute, and ask the question or put it in the chat. But basically, Echo is a hub and spoke model, okay, that is different from traditional telemedicine, as you can see on this slide, where instead of that point-to-point, where you've got the doctor and the provider, this is a group of experts on one end, so around amputation, let's say, and prevention. And then the primary care providers, teams, medical assistants, nurses, whoever it might be on the other end. And the main reason for this kind of model is to hopefully get the knowledge out to as many people as possible at one time, right? Be able to disseminate information in a larger setting and virtually through Zoom. You can see on this slide kind of the goals of the Echo model. So trying to get, treat patients in the primary care setting longer so they get the right care, at the right time, at the right place. We all know in West Virginia, most people who go to their primary care doc want to keep seeing their primary care doctor for as long as they can. They've seen them forever. So that's what Echo really tries to do, is they try to keep them in the primary care setting longer. And on the other end, if they do need to come see a specialist, they come see a specialist at the right time. It's not too early or too late, kind of bridges that gap where the, continuum of care and the quality of care is kind of brought into the middle, where everything kind of works a little bit more efficiently. Okay, this is probably the most important slide of the entire slide deck, is what to expect in these sessions, an anatomy of an echo session. So every session we will do introductions, especially the first couple here. We'll go around the Hollywood squares, but as we get to know each other, we can start doing them more in the chat to save us a little bit of time if we have a couple of cases or anything like that. But at least for the first 2 or 3 sessions, we'll just want to kind of get comfortable, unmuting, getting on, talking to everybody, introducing themselves, even though I know a lot of you have relationships with already established. And then we'll have a didactic presentation. This is usually 20 to 25 minutes at the most. It's around a topic that is going to be very basic. We're not going to try to, give you over information where you're just going to get, overwhelmed or anything like that. This is going to be very nuts and bolts kind of presentations that are, hopefully be able to help you gain more information, ask questions, have a good discussion as well. And then we have a de-identified case presentation. So we can do 1 to 2 cases a session, probably. We'll see how it goes. But these are 5 to 8 minute presentations by one of the participants, typically. We have a case form, which we'll go over here later, but it's an electronic case form. You can fill it out with as much information as you want. You do not have to fill out every box. It is really just to get some ideas down around a case that you could present at one of these sessions. And when we say case, it can be a lot of different things. It can be about a specific person. It can be about a group of patients that maybe share similar, diagnoses or things like that. Or it could be a policy and practice question. What do I do if this patient comes in and they have this? Do I take care of them? Do I send them to you? What should I do? It can be questions like that. So case is a really loose term right now for Project Echo. So anything you want to put in the case, we'll discuss. And then we'll have a kind of a wrap up where I'll let you know if there's any announcements. We'll look forward to the next session and answer any kind of last minute questions, and then we will adjourn. It should be noted that the didactic in the case can be flipped. So let's say you want to present a case, but you can only stay on till 12:30. Well, then you would go first. We would get you on, make sure you were able to present the case if you had to leave. So we can be flexible as far as the agenda and how everything shapes up, but this is what you're typically going to see in the sessions moving forward. Any questions on that? Feel free to unmute. Okay, I'll keep going. This is just to kind of show you, we've been doing Project Echo since 2016. So we've had a lot of projects under our belt. It's been very successful in West Virginia. So we want this to be the same way. We want it to be very successful and more importantly, beneficial to everybody that's on this call. So we really want your feedback. If you think something needs changed on the case form, if you think we need to discuss a certain topic, anything, we really want that feedback. You'll get opportunities to do that with a post-session evaluation link that we'll send out, but you can put things in the chat. If you just think of something while you're on a session, throw it in the chat or unmute and let us know, because we just really want to make sure this is beneficial of your time, because we know you're taking an hour out of your busy schedules to do this. And so if the content's not what you want, that's a problem. We wanted to make sure it's things you want to learn about. This just gives you an overview of where we're at, how many people centers we have throughout the sites. Like I said, we've been at this for a long time, so we we think we have it down pretty well as far as how to do it, but we're always open to improvements and being flexible and changing things when needed. That is it for me. Does anybody have any questions? Okay. That is also called an echo pause. You'll hear that. You'll hear us say that. It's where it's that uncomfortable silence. You know, we're waiting to see if people will unmute, marinate on the question a little bit, maybe put something in the chat. So don't feel free, you know, I didn't freeze or anything like that. The internet didn't drop out. It's just me waiting to see if anybody will say anything. All right, Samantha, yes, let me make sure you can share your screen and then I will turn it over to you. Sure. Oops. Yep, you should be good to go.
Thank you. And so,
Sure.
oh, no, not quite yet. It still has it disabled.
Oh, okay, okay, I'm gonna make you a co-host. So you should be fine now.
It was all part of my plan to take over as a host. Okay, let's see. I'm gonna share screen too, and then I'm gonna launch the PowerPoint, and you guys will have to tell me if I did it right or if you're looking at the wrong screen.
No,
Is this the
looks
correct
good.
screen?
Yep.
Fantastic. All right. It's just a little intro slide I put together. Stole some images from the CTSI website. So welcome everyone. I'm so delighted to have all of you. The number of podiatrists, this is like a dream for a vascular surgeon. I hope you all realize how special it is that we have so many people that are so dedicated from the podiatry side. Like this is the number one thing that places are missing is podiatry. And look at all the folks that we have on here. Speaking of which, thank you. Thank you so much for being here. This is just a quick list of the hub members. So these are the folks that are creating the content, giving talks, and providing important insights to the cases. So here, as mentioned, so Pamela Zimmerman is our Chief of Vascular Surgery. Amy Diamond is the Director of the Advanced Wound Care Center at WVU in Morgantown. Josette, who I don't believe is on here, but she was running wound care out of Davis and has recently moved to the WVU family and is at Fairmont. But she will also be an important voice in teaching us about wound care. I saw Rusty just kind of look a little bit to the side. Did you know that she joined? Well, I'll get you guys connected. So then we have Dr. Michael and Dr. Michael, Jennifer and Addison. Do you prefer Jeff or Addison?
Addison.
Perfect. Okay. So we have Addison Michael on here, and this is an amazing podiatry duo out of St. Joe's that we collaborate with a lot. That's over in Buchanan. I don't think Dr. Findling made it, but he is a private podiatrist. He is the only podiatrist that provides care to Pocahontas County. He goes twice a month on a Saturday. He's been doing it for 11 years. He's the only one that goes down there to take care of the patient population directly. And then Rusty Kane, as we noted, he's on here. He's also a wonderful collaborator at WVU on the inpatient and outpatient side, also podiatrist. Dr. Bozia, Catherine Bozia, who I don't think is on here either. She was planning, but maybe got mixed up with her schedule. She is also a wonderful podiatrist who trained in California with David Armstrong, who's really well known for his limb preservation, and he's one of my mentors. So she's going to be giving some talks as well. And then we have Dr. Michael Hurst, who has been an incredible podiatry partner as well. He and his wife work out of Davis, and he'll be providing things. And he also sent us our first case report, or our first case. And then Deb Loy, who is our specialty nurse and an amazing collaborator as well, basically runs our clinic and all of our patients up here. And then Ranjita Misra is actually public health. She's a behavioralist and works a lot with rural patients with diabetes and changing behaviors to improve self-care for diabetes. And that was something that really came up in a lot of our focus groups about our frustrations with patients not being willing to take care of themselves. And so we asked her to join and to try to give us some insight on how we can get these patients better taken care of. And then finally, Dr. Noriel Vardy, who I got to get on here as our infectious disease colleague, because we didn't find any partners just yet at WVU that want to join us. But yes, she and I did residency together back in 2006 to 2011. I'm so happy that she's near us now and willing to give her insights. So that's the thank yous. Here are just a few quick slides to discuss why we are here. So as we know, amputation is highly preventable. 85% of all lower limb amputations in people with diabetes and vascular disease are preceded by a foot ulcer, meaning there was a wound, it was not treated in a timely fashion, and it could have been prevented. It is a problem of many disciplines, starting with diabetes that's not well controlled. So here's the quote unquote stairway to amputation. People with uncontrolled diabetes then develop neuropathy, develop ulcerations, infection, and ischemia, plus or minus, and that can lead to amputation. So as you can see, there are a number of specialties that would be best suited to help us discuss and take care of these patients. They're very complicated patients. Multiple studies have shown that we can improve amputation rates by using a team approach to limb preservation, up to 86%. And a lot of these multidisciplinary teams are anchored by the toe and flow principle. So podiatry and vascular working together, and then all of our other specialists bringing in their care as well. So I see wound care is not on here. I'm making my own one of these. This is from a publication, but everybody's will look a little bit different. It's really who's willing and able to help. But the deal with this is that this approach has really only been used at high-level tertiary care centers or in outpatient centers of excellence. So basically, we can offer you that if you are willing to come all the way up to some fancy place, but it's not something that people that are living in rural areas or remote areas have access to easily. And so this is where we come in. You already heard about Project Echo, so I'm not going to give a whole slide here, but what's important here is that we know there's a shortage of specialists, and Echo was designed to improve the efficacy of primary care providers to treat complicated patients. And so we are trying to bring this expertise, this multidisciplinary limb preservation expertise out to you all where you are so you can take care of the patient and again, get them the right care at the right time. So goals of this project, Echo Amputation project, is again to empower primary care providers to get the highest quality care. We're doing it in a case study approach. Our plan is to focus on both simple and complicated patients so that you guys feel comfortable managing the patient population. And we're operationalizing, so we're taking the concept of the toe and flow team and bringing it out to the rural area. So I have, I think we have the time. I have a case that's just an example of the type of case that we might want to talk about during the session. I actually had 3 cases, but in this, for time, I decided not to. But I'll say that 2 of those cases, one is a patient that I had an example of just a really great referral to me. So as you all know, I go down to Davis twice a month in person, and we also have a telemed clinic down there twice a month. It is one of the closest locations that you could send your patients. And so I had a great referral from Jennifer Lambert, who identified PAD in a patient that was coming with neuropathy and had severe PAD. And she was absolutely correct to send the patient to me when she has. And right now we're just managing conservatively. But I was really happy when I saw the patient come in. She already had a study, and it was absolutely the right thing to do. I have another patient that Dr. Hirsch sent me that has a non-healing wound that I'm going to be doing an angiogram on. And again, this patient did heal their wound, but he's absolutely correct that they're not going to stay healed, and getting their vascular disease taken care of is going to be very important. So I have those, and I think as those stories evolve, we'll be able to present them as examples. Here's an example of a case that Dr. Michael and I worked on. And I just wanted to show you this as an example of something we might be showing. So here's a way that the multidisciplinary approach has worked. So this was a 60-year-old male who presented with a non-healing toe wound for a month. This is a pretty healthy looking patient. He actually was at Dollywood with his family. He has neuropathy, poorly controlled diabetes. He walked several miles a day in a pair of poorly fitting running shoes. And he developed a first toe ulcer. and went to see Dr. Michael, and they were trying to get it to heal, and it just wasn't quite coming along. He has a history of diabetes, neuropathy, and hypertension, and they got a study, which was appropriate because it wasn't healing in a timely fashion. It had been about a month, and the wound wasn't getting better. So they did get ABIs. And what's interesting about this, and this is something I tell my colleagues all the time, if you showed this to a vascular surgeon, they'd be like, why are you calling me? Like, this looks pretty good. But through my work with Dr. Michaels and Dr. Hurst, if you guys don't think it's right, oftentimes when I look at that foot, you can tell from a mile away that someone has PAD when you have experience, and it's worth doing an angio on some of these patients. This patient in particular, his toe pressure was 39, which is not adequate for wound healing. So that was enough for me to take him because he had highly calcified vessels. And this is, here you can see they could not get the ABI pressures. It's the CNO means could not obtain, probably very calcified, erroneously elevated ABI, even though the waveforms look pretty good. I thought it was worth checking. Here's what the toe looked like. So in August, the patient came in with this. This is just rubbed when he's on family vacation. About a month later, this is what the wound is looking like with close wound care. And then when they decided to send the patient to me, you could see that this is not healthy. This is not pink and bleeding. They've developed a fibrinous exudate on it despite appropriate debridement and treatment. So I took the patient for an angiogram based on this plus the toe pressures. And you can see here's the popliteal artery. There's a high-grade stenosis there. There's some disease in the anterior tibial artery proximally. And then distally, there's some junk over here in the distal anterior tibial artery. And there's even a small occlusion in 2 locations. We were able to open up the popliteal artery and the proximal anterior tibial artery. And I got a fair bit of flow. There is still this about 1 centimeter occlusion, but it's still pretty good. And so these are the post images. And you can see here now, I mean, they couldn't even get the ABI. This just proves that there was significant disease, but you can't always pick up on it, but the toe pressures improved significantly. And that's often why we use toe pressures, because you can't always trust ankle pressures in patients with diabetes in particular, because they get calcified. So here's what it looked like a couple weeks after. And then this is actually, we're looking into, they did an Apligraph application. Dr. Mike, so they've been following with him, doing multiple Apligraph applications. This is December, getting it close to close. And here we are now in March, and still can't get it closed. It still keeps opening. At that point, they do get an x-ray that shows a possibility of osteo. And I just learned this from the chart because I was out on maternity leave. He did follow up with us and his numbers were looking okay. But based on concern for osteo and non-healing wound, they ended up doing a distal hallux amputation, which now has healed. So that's kind of the story of this patient. It's quite a saga. Starts in August, goes until May, where he finally heals. This is not unusual for a patient with diabetes, and this is his other foot. So this is obviously a recurring problem that we have to be very careful about. And really, there are a number of people I think that we could rope in on these kind of patients that would be helpful. And I wanted to have just Dr. Michael give a little bit of comments on his experience with this patient and anything else he'd like to add.
Yeah, this patient, we had some issues. He was healing pretty well with the Apligraph, and once we were able to reestablish some of that blood flow there, one of the big issues was compliance with offloading, and he had some problems where he went out in the woods doing a lot of walking, and I think he was searching for a dog or something like that, and that led to some worsening of the infection process, which ended up with the osteomyelitis. But I don't think that he would have even healed this amputation had he not had the vascular procedure performed to establish that better blood flow there.
And as far as, the osteo, what made you think that it was osteo?
You can't see it as well on this view, but on his AP view, he had some cortical erosions on his proximal medial cortex, the distal phalanx there, which is pretty indicative of osteomyelitis in there. And his path report did come back with osteomyelitis. once the amputation was performed.
But why did you even check for osteo?
Because of the progression of the wound. So it was getting slightly worse. He was not showing progression like he had been in the past. And then, like I said, he had that incident where he did a ton of walking, and we had done a couple rounds of antibiotics with little progression. So I like to check these patients to, routinely if they aren't progressing with serial radiographs, just to make sure they aren't having any changes within the bony prominences that are under the ulcerations there.
So I think some take-home points there for our colleagues is if the wound's not healing, an X-ray would be indicated to make sure there's no underlying disease. I think from our perspective, being able to talk about a patient like this and saying, they're not healing, and having someone with an infectious disease background even to say, what antibiotics are you using? How long should they be on it for? That kind of stuff might have been helpful. Also, I don't know what his last hemoglobin A1C was, but boy, it'd be nice to have someone with endocrine experience that might be able to chime in as well.
I would just want to bring out something that Dr. Mintz had said about, although the studies looked good, the non-invasive studies, we didn't have a good toe pressure, but frequently the studies can look good in these diabetic patients, but we want to always, if we have a palpable pulse, then usually we could heal. But for some of these patients, it can be great down to the transmetatarsal, and then we cannot feel a pulse, and they really should have an intervention if we can't feel pulses in patients. Even if the studies look okay, we should still be doing an intervention to revascularize them.
Did any of our other colleagues want to mention anything? I'm just thinking there's just a lot of different, like having someone that can get a good offloading device to the patient. And now looking at him and how he's probably lost a lot of muscle tone, and wouldn't this be a great patient to get into a PT program to make sure that when his foot muscles are appropriate, so that when he starts walking again a whole lot, he doesn't cause himself to re-ulcerate, as you see from the last picture. These are things that I think about, that if we have a strong multidisciplinary team and discuss these patients, we can maybe get all of these things coordinated.
I had a question. Outside the allograft, was he using any other wound care devices other than the allograft after the allograft application, such as collagen or something to get the wound to close? The other thought I had too, in a patient like this, in looking at amputation prevention, I don't know where he lives, antibiotics and HBO therapy, hyperbaric oxygen therapy after a course of antibiotics is a medical option, to consider in some of these patients when you have resumed flow. It may, I'm not sure the patient's medical history, but I always throw that out there, prior to amputation, if they've had osteo, is that medical therapy with IV or antibiotics followed by HBO, is also another thing to think about in the right patient.
Yeah, I think he where he lives, he'd be about an hour and a half, maybe a little bit longer, to the closest facility with HBO therapy. He did have a couple other treatment modalities. We did do some collagen. I'd have to go back and check, but I believe we also did Santal on him as well, and then just some standard betadine treatment along with the allografts. We tried several different modalities on him. Transportation was an issue as well, getting him to different places just because of where he lives and how far out he is.
From a primary care perspective, does anyone have any comments or questions?
Sam, I don't have any like primary care, but did anyone reach out to like orthotists, not in this particular case, but for our group, like Hanger or any of those groups as far as like offloading techniques and things like that? I think they'd be a valuable source for the Echo project as well.
That's a great idea. So I would say the closest Hanger, and you all can help me out here. A UHC has a Hanger. I don't know, Pocahontas is a bit distant from there. Do you know if the guy that we have coming up from Greenbrier could provide that kind of shoe, or he's just providing offloading? So we were able to locate somebody that's coming to our podiatry or to our offices in those areas that's doing diabetic shoe fittings for us and providing those shoes. But I don't know if he maybe also has offloading capabilities, because that is something that we could try to coordinate.
I know that's one of the biggest challenges I have with patients, and I'm sure Amy and all the podiatrists also have it. It's, getting them in touch with somebody, or like you said, location wise, it's sometimes difficult for them to get. I carry a few offloading devices in the office, but that's a challenge always.
We can talk to them, and we can also talk to Hanger to see if they would be willing to get things ready to ship or something like that if necessary for these patients. I know from a primary care perspective, I think there's probably some things like their diabetes management that we're not thinking about that maybe you all would have better insight to. Nutrition as well. Well, this is, the first example case. I just wanted to show you the type of cases we may discuss. By the time we're done, I think you're all going to be comfortable with what the usual flow of care is going to be for these sort of patients. I want you all to know, like, okay, well, they'll need to go somewhere to get debrided, and then they're going to need, probably to be assessed. Their vasculature is going to get assessed. Okay, now they're going for that angio. They're going to come back after that, and just to know, it's pretty basic flow of how we take care of these patients and what we think about. So I want to be able to give you that knowledge.
Hey, Samantha, I saw Quentin, you unmuted. Did you have a comment or a question?
I was just thinking about, when she asked about primary care insights, it's tough to say without, seeing all those numbers and where those are at.
Couldn't find his numbers, but I think they're Davis patients, so that's the problem. But I think in the upcoming one, that's going to be something where we might show you, well, we will dig for numbers, and anything that you want to get done, let us know.
I guess maybe a bit of a question too, just kind of triangulating with the ABI PVR orders. If I recall from working with Dr. Diamond back in residency, learning from her about the importance of those and their results to kind of how someone is triaged in the vascular surgery view. And so then I tried to, while still in residency, I tried to incorporate and order those some from Town Center in my primary practice, but then found that they would not necessarily get covered, and at least WVU and Morgantown would say, oh, they've got to see vascular to get those ordered. And so I was a little stumped. I'm trying to, I think now down here in Pocahontas, I've had 1 or 2 patients where I've ordered just kind of the regular, maybe I've had one that I got the PVR, but I'd be curious on any comments as far as where those can be accomplished from, primary care pen in our
We
footprint.
can get them up at Buchanan. We're not affiliated with Davis anymore, so we can't see the images from Davis. But if they absolutely can only go there, we can do that. As you all know, they have about a 3-month backlog. It's a huge issue. However, if the wound's not healing and it's not making sense, then I think, especially with this platform, or, you have my cell number, you can always ask me. We will see patients at this point, knowing that it's so hard to get this study. We will do that ahead of time.
Okay, yeah.
And it might be worthwhile if Quentin is saying, because that's what I do teach them, and if it's some sort of epic issue, if they're ordering the correct test as a workup of a new wound on a lower extremity and epic, and the system isn't allowing the PCPs to actually get their patient's schedule when they've ordered the proper test, to me, that seems like an epic issue. I'm not sure why you have to be, I'm not a vascular surgeon and I order them, so why their access is blocking them from ordering that test. That might just be some technical epic issue that, maybe somebody could look into so that we aren't missing these people that are being, appropriately worked up by the PCPs.
Right now, the only test that is sometimes limited to a vascular surgeon ordering it is the venous insufficiency study. Just that takes a long time to complete. And what was happening is sometimes people would want to check for a DVT and they would click on a venous insufficiency study. And that's why we did limit that study. Is the only one that we recommend, that you get vascular involved. But other non-invasives, ABIs, PVRs, all of those should be open to anybody of that wants to get those non-invasive. So if there is a problem, feel free to even reach out to me and let me know so we can make sure that your patients can get the testing. It's disappointing to hear, someone can't get testing because you had frustration with ordering it. So I agree with Dr. Diamond. We want to make it as user-friendly as possible. So please feel free to reach out to me if there are issues with that.
That said, these folks are not part of the Epic system. They are.
Oh, okay.
Different.
Okay.
And the whole point of this is to be helpful to people across the state. Quentin, are you able to order for like a study from Buchanan?
Yeah, I should be able to. There's pathways through our EMR now. It just ran into that while still in residency on Epic, and was wondering if there was some overarching principle that I should be aware of as far as the restriction on those being done from primary care. But I think that those answers were helpful, and I don't foresee it being an issue here, so long as I pick the right sort of destination facility.
But I would say ABI is our biggest limitation. We've gone over doing the exams with you guys. If it doesn't look right, send it. I think it's just what we have to do in our setting of care. So, does anyone else have any questions or comments before we go over the case form?
Dr. Mintz, could you stop your screen share so we can see everybody, make it a little bit easier see if there's questions? And I think we're getting close to almost at 10 minutes. And so maybe I'll share the what the case form looks like, but we might, Michael, if it's okay, save the case then, so we give you proper time to walk us through it, if that's okay.
That's fine by me.
Okay. Yeah. I don't want to be run up against it and have you feel rushed or anything. But does anybody have any other further questions? This has been great.
I had one question. So when, for this previous case, I was just curious what kind of ID support you had in terms of consultation once the osteomyelitis was diagnosed, and was there somebody who was able to give you input and get patients started on the right antibiotic? I'm just curious to see the support available currently.
Yeah, so once I got the x-ray with the osteomyelitis, patient was offered amputation versus 6 weeks IV antibiotics. At that time, he chose to go with the amputation as opposed to the IV antibiotics. We do not have ID at our hospital. the closest one for him would be up in Bridgeport, which is difficult again for him with driving. So don't believe, I'd have to double check if we did an ID consult at that time or not.
Because I'm as an ID physician, we're always looking at the vascular supply before we prescribe antibiotics for osteomyelitis. And looks like this, in this case, the vascular supply had been corrected. So there is a chance that he may have healed with the 6 weeks of antibiotics. It's still tough when the bone is already necrotic, that the antibiotics are going to make much difference. So there is a possibility that you may still end up with amputation despite the 6 weeks of antibiotic course. But I think this is a perfect case where if I was seeing this patient post angioplasty, that I would definitely have, if the patient was interested, would have tried antibiotic course to see if we could, save the amputation.
I'd also add, I do think this case is a win, in my opinion, because he ended up with a partial toe amputation rather than a baloney amputation. And that's honestly the goal at this point is, trying to do that. I do think there is a conversation. I know that I saw Dr. Michael had done x-rays every 6 weeks or so. And this March was the first time that there was any evidence of osteo on it. So I am curious if from an imaging perspective, is there a certain point where you say the x-ray is not good enough, you should get an MRI, it's been too long, there's the vascular supply is there, it's taking too long, you should do more investigation? Or do you just do antibiotics and assume there's osteo? What is the approach?
This is directed to me, right, Samantha?
Yeah.
Okay. So I think the biggest thing which was rightly identified was a non-healing wound, right? I think that's what prompted the imaging. And if it's really clear on the x-ray, we don't necessarily go for an MRI. The only time I would go for an MRI, actually, if we're planning limb preservation or because it's helpful to see the extent of the osteo, which can sometimes be missed on an x-ray. So if we were planning to do 6 weeks of antibiotics in a follow-up study, that's when I would like to see an MRI to see if we do a post 6 weeks, if they're kind of in the same situation, can we do a repeat MRI and see, have we seen an improvement? Is there a progression despite antibiotics? Because that might help guide our management in terms of, are antibiotics even helping at this point or not? If they're helping, if the osteo has decreased, the wound is starting to heal, I always say in denuded bones, and the bone remodeling can take so long that sometimes we do IV antibiotics and then switch them to oral antibiotics to help prevent infection while the bone remodeling is taking place. So of course, in osteo, there can be a complete imaging lag. You can see inflammation and osteomyelitis as lingering, even though the infection has actually been treated. But that's made, that's where we monitor our ESR, CRP, wound, what the sugar control has been like, has the wound completely healed or not. So I don't always jump to MRI, but that would be in the limb preservation plan. Sometimes I would consider an MRI in these patients.
That's really helpful. I don't think we have that approach even where we are. I wish that we did.
And I'd piggyback on that. You would also need it if you're considering hyperbarics after that. You would need that to get it approved. So often in those cases, but I agree with Dr. Narul. I mean, if I see it on x-ray, I don't always get an MRI. If you see it, you see it. But if a patient is being considered for limb preservation, hyperbaric oxygen therapy, you're going to need an MRI for insurance authorization.
Well, this is the kind of stuff that everyone's going to learn about during our sessions this year. Is that exciting?
The answer is yes. Even as somebody who's not a physician or anything, this is super interesting. Really appreciate the conversation. Does anybody have any more comments or anything? We still have about 6 minutes. Don't want to stop anybody. So if you got something, please unmute. Okay. Hearing none, I don't see anything in the chat. Real quick, let me show you what the case form looks like. And it's pretty straightforward. This is an electronic case form that can be filled out on your phone, on your tablet, on your computer at work, whatever. It works across all platforms and all devices. There are some required values, and this is really just your information. So where you're from, your email address, your name. I want to turn your attention though to the presentation date. Let's say you can't present at the next session in August, but you're around in September. You can absolutely go ahead and submit a case when you have time and mark what month you want to present your case. That way it's flexible to your schedule. So just because you're filling out the case form now, let's say you wanted to fill it out tomorrow, that does not mean you have to go at the very next session in August. You can sign up for the month and the day that you works best with your schedule. So please keep that in mind there. You can copy and paste into any of these fields. So if you have information on your EMR that you just want to, like a note or something like that, and you just want to copy and paste it in, you can do that. Just be mindful, we can't have any PHI in the information. So just be sure to take that out. The same thing with if you are uploading an image, which we do have that capability on here. It's down here. There's some information here. Can't remember where it is. I will have to look at. I know there's an upload. It's probably in the branching logic, but you can upload a photo just like so, an X-ray or something like that. Again, all we're asking for is that if there's the patient name or something like that on it, to just crop that out if you're uploading that image. There is, like I said, you can fill out all this form. There are certain questions that we do want you to fill out, but if it's not marked as required, you do not have to fill it out if you don't know the answer or you don't have the information at that time. So just let us know if you have any issues with filling this out. Again, it's just a REDCap survey link, so it's pretty open to any web browser and anything like that.
I did want to add,
yeah,
I'm sorry,
sure.
if there's a patient that we identify, that we discuss, and there may be certain specialists we identify within here that might want to help you manage the patient. That's why Deb is on this, because she is an excellent navigator of patient care. And we will go offline and we can get more details about the patient and plug them in so that you all can get the care for your patient. Just wanted to add that because I know we're de-identifying them because this is a learning experience, but we also want to provide that multidisciplinary expertise. And so if we come up with a care plan and we need to get that navigated, that's why we have Deb on here, because she is absolutely the best when it comes to that.
That's a great point. Yep.
I'd like to echo that because down in Fairmont, sometimes I'll book somebody for some non-invasive tests and it'll be like a month and a half or 2 months out and they need them right away. So Deb's always very, very helpful, helping me get them in faster.
You're making me blush.
Yeah. Pressure's on, Deb. Yeah. I was just well, we've got a couple of minutes left. This is part of the session. We'll just kind of wrap things up. Our next session is going to be in August. It's going to be August 15th. Same time, 12 to 1. You'll get the reminder again 30 minutes before to join the session. You'll also get a recap email from myself about this session. That'll include the recording to the session, the PowerPoint presentations we reviewed, and information on the next session. So you'll be getting those. But at any time, you can log into your iEcho account, which you did to join the session, and all the content will be in there as well. So the presentations, the video recording, all that will be housed in there. So you'll have two options of accessing that information. And again, at any time, if you have any issues, questions, anything like that, please feel free to email me, and we'll see you in a month. Thanks everybody for coming. This was great. Great first session. All right. Take care.